Marionette lines. Marionette lines, the anterior mandibular line and the chin, are three anatomical structures located in the antero-inferior part of the face. They evolve synchronously, with maximum aging starting at 50 years. The lower maxillary is the bony structure that forms the base of this region. Aging of the lower part of the face is the result of contraction of the depressor skin muscles and changes in the adjoining fatty layers. Marionette lines are the result of, on the one hand, contraction of the depressor anguli oris muscle, resulting in marionette lines, and of the platysma muscle, which interdigitates in the front with the posterior fibres of the DAO. And on the other, ptosis of the adipose compartment, and more particularly the superficial compartment, which forms the jowls and contributes to the accentuation of marionette lines. These anatomical phenomena are accentuated by other elements: the presence of a fixed ligament, the mandibular ligament, retrogenesis, reduction of the height of the lower facial area. The main anatomical precautions of the injection in marionette lines concern the facial pedicle, which enters the region via the submandibular notch by precrossing the mandibular edge, as well as the facial, motor and chin sensory nerve. Pathognomonic sagging of the facial tissues and muscular hyperactivity, marionette lines can extend from the labial commissure to the mandibular line. They give the face an appearance of fatigue and sadness and are a frequent indication given their anatomical prevalence. Several techniques can be used depending on the severity of the marionette lines and the physiognomy of the face. We most often choose a netting or grid technique with two crossed fans allowing to fill and provide sustentation for the marionette line depression. The first insertion point is located at the lower tip of the marionette line and the fan is directed upwards. If necessary, a second insertion point is made immediately outside of the marionette line. This fan provides complementary filling and sustentation of the hollow. After disinfection, insert the needle at the lower end of the marionette line at a 30-degree angle, and then change the tilt of the needle to be parallel with the cutaneous plane. Continue inserting the needle into the desired cutaneous plane and then make a retrotracing injection withdrawing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the needle from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. With Radiesse, the product deposit and correlated correction are assessed immediately. Massage and shape the areas injected to evenly spread the product. The marionette line can also be injected using the cannula and the same techniques. The results obtained using the Radiesse injection are as follows when correcting marionette lines.